are the management options when a patient comes with metastasis? This is getting more and more complex every day, and the number of treatment options are too many. It's surgery, surgery followed by whole brain radiation, SRS followed by whole brain radiation, SRS alone, whole brain RT alone, or you do surgery followed by SRS boost to the tumor cavity with or without radiation. And of interest is one of the articles I read said you do SRS first followed by surgery. So how do you select a patient, which treatment to give which patient, and what is the role of surgery? I think you have to look at the primary cancer, whether it's controlled or not. What is the general condition of the patient? What is the neurological status? What is the extent of systemic cancer? And then the last 3 points help us decide whether to do surgery, SRS, whole brain RT. I will discuss each of those one by one. Number of lesions. If you have a solitary or single metastasis, surgery or SRS, both followed by whole brain radiation therapy, that is the standard treatment at present. From 1 to 3 metastases, SRS with or without whole brain radiation therapy. And for 4 or more metastases, the current treatment is whole brain radiation therapy, although more and more people are doing SRS for multiple metastases. Location. If it's something very eloquent cortex, like this case in the thalamus, with a small lesion, this is very suitable for SRS. Something which is in the non-eloquent cortex, especially if it's in the posterior fossa, we would do surgery to reduce the intracranial pressure. Size of the lesion is very important. Tumors which are 1 centimeter or less, they are ideally suited for SRS. And tumors which are more than 3 centimeter, something like the second image, which shows mass effect and midline shift, that would be a candidate for surgery. And the real so-called equipoise, where everything being equal, the tumor size between 1 to 3 centimeter, for that either surgery or SRS. And one more thing which makes, which you can base your decision for either surgery or radiation or SRS is the histology of the tumor. Some tumors which are radio-resistant, like melanomas, renal cell carcinomas, and sarcomas, are ideally treated with surgery. But if you can't do surgery for them, SRS is better than fractionated radiation therapy. This is just to show you an example of a young man who came, 32-year-old, with raised pressure. This was the tumor on the MRI, which appeared cystic with a nodule. Our initial diagnosis was that of a cystic glioma. We operated this patient, and it turned out to be a metastatic adenocarcinoma. This is to show you the importance of histology and the varied radiology. I have put some Ommaya reservoirs for my colleagues in oncology, and also we have to do sometimes shunt, VP shunt as life-saving procedures in case of hydrocephalus, which is usually seen in posterior fossa masses and meningeal carcinomatosis.